Good day. My name is Risaho Passman, and I'm from Botswana, and my teammate is Keith Kimplingen from Kenya. And our presentation examines whether national healthcare systems should cover BRCA1 and BRCA2 genetic testing. And as the negative team, our position is that widespread national coverage is not yet feasible or sustainable for African countries. And therefore, we argue not against the value of genomics, but against premature implementation that does not align with the current system capacity. BRCA1 and BRCA2 are genetic testings which help identify individuals with hereditary risks for breast and ovarian cancers. While the clinical value is clear, African countries face major resource and infrastructural challenges that affect feasibility, and many health systems are overstretched and still dealing with high burden diseases. Therefore, our argument focuses on whether wide-scale national coverage is realistic under current conditions. Genomic medicine is important, and BRCA testing can significantly contribute to precision oncology. However, effective public health policies must balance benefits with system readiness, cost, and capacity. At present, most African countries lack the financial resources, infrastructure, and specialized workforce needed to support nationwide BRCA testing. And our position is that full coverage is premature under current circumstances. For our constructive arguments, we have multiple. And to begin off, we have financial constraints. BRCA testing is highly costly due to the technology and expertise required for sequencing and interpretation. And national health budgets are already strained by priority health issues such as HIV, TB, malaria, and maternal health needs. Allocating funds to nationwide BRCA testing would divert resources from higher burden diseases and without clear cost effectiveness data for African populations, these expenses will be difficult to justify. Another constructive argument we have is inadequate laboratory and genomic infrastructures. And African countries have limited accredited genomic laboratories capable of conducting BRCA testings, and many rely on sending samples abroad, which increase costs and causes significant delays. And local laboratories face issues such as unstable supply chains, maintenance challenges, and equipment shortages. And without strong genomic infrastructures, national rollout will be unreliable, slow, and efficient. Shortage of skilled personnel. To have an effective BRCA testing, we require highly trained professionals, including genetic counselors, molecular geneticists, pathologists, and other specialists that are highly trained in these fields. And many African countries currently have a very limited number of these experts. Therefore, offering nationwide BRCA testing without adequate workforce capacity, risk and accurate interpretation, poor patient support, as well as ethical issues around informed decision makings. Constructive arguments continued. We have low awareness and social cultural barriers. And that is, in many communities, awareness of hereditary cancer remains very low, and misconceptions or stigma surrounding geneticists persist. Mistrust of genetic testing may reduce uptake, and even if the tests are free. Without robust public education and community engagement, national coverage would likely see poor utilization and may deepen misunderstandings around cancer and genomics. We have very limited data on BRCA mutation prevalence in African populations due to underdeveloped cancer registries and insufficient genomic research. Policymakers lack reliable evidence to justify large-scale investments, and implementing national coverage without population data could misallocate these resources and fail to target those at highest risks. We also have risk of worsening health inequities. whereby BRCA testing will primarily benefit urban populations where labs and specialists are highly concentrated, whereas in rural and remote communities will lack access to genomic services as well as oncology care. And introducing the BRCA coverage without addressing these gaps that are already existing will risk worsening existing healthcare inequities and could create a service that will only benefit a privileged minority. While the affirmative side may have emphasized the benefits of early detection and prevention, these benefits rely on strong follow-up systems, and without adequate counseling, surveillance, and treatment capacity, positive test results may not translate into improved outcomes, and therefore the testing alone will not be sufficient. That is, the health system will not be able to support the full continuum of care. And even if external partners or donors assist initially, these programs, they must be sustainable for a long term. And genomic programs that rely heavily on external funding often collapse once funding ends. Therefore, we need a phased approach that builds capacity before committing to national coverage and the system at risk. African healthcare systems are not yet ready for a wide-scale BRCA testing. There is insufficient genetic counseling capacity, limited access to MRI screening, as well as inadequate availability of risk-reducing surgeries. Testing will also require long-term data management and patient follow-up. And these systems, they are still very underdeveloped in a lot of African countries. Therefore, implementing BRCA testing would likely benefit only those in urban areas with access to special care. And why premature implementation will be risky? It will be risky because implementing the national BRCA testing without readiness could waste scarce health resources. It may widen disparities by mostly serving a small privileged group. Health systems are not fully equipped to handle the ethical, clinical, or logistical demands of hereditary cancer programs. Therefore, introducing such testing too early could undermine trust in genomic medicine and create unsustainable expectations. Genomic medicine has tremendous potential for Africa's future, and every citizen deserves access to high-quality cancer prevention and care. However, responsible policy making requires aligning ambition with capacity. And before national BRCA coverage can be considered, countries must address health systems and gaps to ensure equitable and sustainable implementation. And rather than just rushing into wide-scale coverage, countries should focus on strengthening foundational systems, which would include national screening programs, oncology services, laboratory capacity, trained genomic professionals, ethical frameworks, and data governance systems. And once these areas are strengthened, BRCA testing can therefore be introduced in a way that is ethical, equitable, and cost-effective. Our position is not anti-genomics. However, it is pro-readiness and pro-equity. At this time, wide-scale BRCA testing should not be covered by national healthcare systems. And the goal is to build the first necessary infrastructure and workforce to ensure that when implemented, BRCA testing benefits everyone fairly and sustainably. And with stronger systems, BRCA testing can be a part of a future that supports precision oncology for. These references support the ethical, social, infrastructural, and policy considerations discussed. They highlight the need for responsible genomic integration, data sharing frameworks, as well as precision public health strategies that will consider local health systems and capacities. I'll be happy to take any questions and address any points of clarification regarding our position and the reasoning behind it. Thank you.